So clearly picking up these fusions, though they're very rare, is extremely important for these patients. So what's the best way to do it? And I want to emphasize that to date, the vast majority are picked up in the context of chromosomal rearrangements. And so cytogenetic analysis remains an important test for these cases. And you can use FISH to look for disruption of particular genes, but that gets rather expensive. RT-PCR is important, or FISH for the FIT101 PDGFR alpha fusion, because you won't detect this by standard cytogenetics. In some countries, certainly not in the UK, you can do an empirical trial of imatinib to see whether patients with eosinophilia, for example, may respond. You'd expect a response within 4 to 6 weeks. We've been looking at the utility of phosphoflow to look at inhibition of STAT5 phosphorylation in response to specific inhibitors in vitro, been used successfully for Philadelphia-like ALL. Overexpression assays, which we don't talk about, but I think the future here is really genomic analysis. And this can be done from RNase, RNA-seq, or for genomic DNA, paired-end sequencing. And the concept's very simple, is that you have fragmented DNA or cDNA, you sequence the ends, map it back to the reference genome, and you would expect these to map a KB apart if nothing's gone wrong, but if you have a translocation or other rearrangement, one end will then be paired with an end from a different genomic location. And what we've certainly found is that the key to this is having sufficient sequencing depth and length of reads so you can begin to get reads that actually span these translocation breakpoints, either the DNA or the RNA level, and that really increases the confidence of detecting these things. So we've picked up quite a few unique fusions in conjunction with unique translocations. What we've been looking for are cryptic fusions that may have been missed, and we found a couple. These are very rare. Here's one. This is a rearrangement on chromosome 13, ZBIM2 FLT3, and this is a rearrangement on chromosome 5. And I'll just show you this case, which we published quite recently. I don't know how clearly you can see this, but these are the two genes, ZBIM2 and FLT3 on chromosome 13. And what has happened, there's been an inversion, an 8 megabase inversion that's joined these two together, giving rise to an in-frame tyrosine kinase fusion. And this is very rare, but it is recurrent. We picked up 2 cases with aggressive myeloid disorders in this fusion. One died after progression to AML quite rapidly. The second case was treated off-label in Germany with sunitinib. So here you see this is eosinophils here in red, leukocytes in blue, clear hematological response to sunitinib. There was some toxicity, so the patient stopped, counts rose, put back on again at a lower dose, and the counts fell again. And further follow-up is awaited on this case. A couple of examples here of cases with JAK2 fusions. This is the standard PCM1 JAK2 that WHO recognizes. This was a translocation which we knew involved JAK2 by FISH, but this hadn't been described before. It turned out by RNA-seq that this was hiding a BCR JAK2 fusion. Both responded to ruxolitinib, chromosomal remission, but both then lost the chromosomal remission over time, and both were then successfully transplanted. So with these more aggressive fusions, particularly those involving FLT3, JAK2, FGFR1, there's no evidence yet that TKIs alone can cure or potentially cure these patients, but they may be a useful bridge to other therapies such as transplantation. Just very briefly, moving on to chronic neutrophilic leukemia and atypical CML. We and many other groups have been looking at these genomically, doing exome sequencing. You pick up a load of stuff, and many of these genes are mutated in other disorders, so prominently they're ASXL1. But there are 2 particular genes of interest in these diseases that really stand out as being almost uniquely associated with these disorders, and that's CETBP1 and CSF3R. And CSF3R is associated strongly with chronic neutrophilic leukemia, as described by Jeffrey Tyner a few years ago. More than 60% of cases are positive. It's not unique to CNL. It's also seen in some cases with atypical CML. And CETBP1 is also mutated in these diseases, as well as JAK2 V617F. And the great interest is that so CSF3R encodes the granulocyte colony stimulating factor. That's a receptor that requires JAK2 for its function. And in the original paper, there was some preclinical evidence in particular suggesting these patients may be responsive to JAK2 inhibitors. And there's an ongoing trial based here in the US, which is still recruiting for patients investigating the activity of ruxolitinib in atypical CML or chronic neutrophilic leukemia with or without these CSF3R mutations. Just as an aside, there's an interesting, I think, parallel between different MPNs in how they develop. So this is work of Tony Green many years ago. This is MPN. MPN is driven by mutations in JAK2, MPL, or CALR, and these can be acquired directly and drive the disease, or they may be acquired on the background of a clonal or presumed age-related clonal hematopoiesis. So then JAK2, for example, is secondary to a TET2 mutation, and these can give rise to an MPN phenotype. Similar thing with mastocytosis, driven by KIT D816V, can be acquired, if you like, de novo, or on the background of other mutations, and that's very often seen in the context of an additional hematological neoplasm. Indication, the same thing's true for CML. From the Korean group, published earlier this year in Blood, I think it was 16% of cases appeared to have BCR-ABL on the context of other mutations. And as explored by a recent review in Blood by Jeffrey Tyner, this appears to be the case in chronic neutrophilic leukemia as well, driven predominantly by the CSF3R T618I mutation, which may arise by itself or on the background of age-related clonal hematopoiesis. I think the challenge here is in all these different scenarios is to understand what differences there are, if any, in clinical outcome of treatment with targeted therapies, depending whether a patient goes this way or this way. This just shows a local case we had with chronic neutrophilic leukemia, had 2 CSF3R mutations treated with ruxolitinib. So these are neutrophils here in green, the mutation burden here in sort of purple. So this patient didn't achieve molecular remission, but this is one of the first cases that showed a very clear molecular response. However, the clone then grew back for reasons we don't know, preceding by some time hematological relapse. And this just shows the reduction in the 2 mutations here. And this is my final slide. This just shows the breakdown of atypical CML, which is a complex disease, a poor prognosis disease. There are some obvious targets here. There's a nice case report of a single case with an NRAS mutation treated with a MEK inhibitor who had an excellent response. But I think we need to understand what CETBP1 is really doing and how that may be targeted, as well as how some of these other things can be effectively targeted to progress therapy for this disease. Thank you very much.